All right. Good morning. We're going to go ahead and get started. We're on a moving fast here early in the morning. My name's Emily Earl-Royal. I'm one of the third-year residents at Stanford in the emergency medicine program. I'm here this morning with an awesome team of people, and we're going to talk to you about implicit bias in trainee evaluations. This is Alai Alvarez. He's one of our assistant program directors.
Morning.
Daniel Hernandez is an awesome one of our emergency medicine interns. Nancy Rivera is pediatrics intern from Stanford. Ripple Shaw is one of our faculty in psychiatry. Carmin Powell is one of our faculty in pediatrics. And then Mike Gisondi is our vice chair of education in the Stanford Emergency Medicine Department. So this talk is entitled, John is Confident, Jada is Too Assertive, How to Recognize and Minimize Bias in Written Trainee Evaluations. So why did we come up with this topic? I think implicit bias is something that affects all of us, all of the time. And so I was thinking back when I was in kindergarten, I did an experiment on my own where I counted the number of times when a boy and a girl student were raising their hands, the number of times the teacher would call on the boy instead of the girl. And I did my own research experiment, and then I shared the results with the teacher as feedback. She was not super excited to get this feedback. My mom was called. The beginning in a long life of my mother being called. But, you know, I think even as like a 5-year-old in kindergarten, this is something that was obvious and apparent to me, and I didn't understand what was going on. And so that's really just continued throughout life. So the goals, if I stand in the correct place,
I'll just click.
Thanks. So our objectives, we're going to define implicit bias and recognize how that impacts written evaluations for trainees, review current best practices to minimize bias in written evaluations of trainees, and then we're going to do some interactive analyze and editing a couple of examples of bias. So our first small group activity, there's some blue sheets. If you don't have one, you can come forward. There's some up here. I promise I don't bite. So if you could take a pen and on these blue sheets, read through the 2 examples and underline or circle words or phrases that you think might contain implicit bias. So we're going to do this for about 5 minutes.
Thank you, Emily. Again, my name is Daniel. I'm one of the first-year residents at the Stanford Emergency Medicine program. And I'm going to talk about why this matters. Why does implicit bias matter? And I think in order to understand why this matters, we have to first define it, and we have to know how it affects us as trainees. So let's go on the next slide. So how do we define implicit bias? It is defined as the set of attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. And let me highlight unconscious manner. Because this is, in other words, the way that we see the world, the way that we act, in a way that we don't know, in a way that we are not aware of. It can be either favorable or unfavorable, right? Just like stereotypes can be positive or negative. And this is something that originates, it's something that originates throughout time. It's the way that we're nurtured, it's the experiences that we have, and it is also things like the media, for example. But how does it affect us? So let's take, for instance, things that we believe to be objective throughout our medical training. For instance, our medical school clerkships, or medical student performance evaluation, or MSPE letters, or things like residency and fellowship evaluations. And let's put it through this filter leading to leadership positions. And let's go back to the other one. So the way that we get evaluated throughout our medical careers matters, because at the end, it's going to affect the opportunities that we have. For instance, getting nominated or selected to things like AOA, residency spots, fellowships, and leadership positions. This is a slide that is basically just summarizing a study that was done in 2007 that looked at over 2,400 medical students across various medical schools. And they found that when you control for things that are more objective, such as step 1 scores, you still have URMs or underrepresented minorities performing or being evaluated with lower grades in all the clerkships compared to everyone else. And this is for all the clerkships. Okay, let's look at the next one. This table is essentially summarizing, it's taken from a study that looked at over 6,000 medical student performance evaluations across several programs. And it found that when it was looking at the way that race and gender is affected in MSPEs. So if we look at this table, it's only looking at race. But if we look at the highlighted section, white medical students are more likely to be evaluated or described as exceptional, best, and outstanding compared to every other race in this table. Another study was looking at how gender is affected through implicit bias, and it found that women are oftentimes more described as compassionate, enthusiastic, and sensitive compared to their male counterparts that are described as quick learners. Okay.
So this study was recently published in 2017, and here once again we're looking at differences, demographic differences, and disparities in AOA membership. So if we look up top, sorry we don't have a clicker, but another thing important to notice is that this is also comparing 1989 with the current time, 2015. So if we look at it, the white students tend to be overrepresented in each category, regardless of time. So even though, oh, thank you, great. So we can see here that regardless, white students in 1989 made up 85% of the medical student body, and 92% of those made AOA. Jump forward many years, lots of social changes after in 2015. White students are still making up the majority of U.S. medical students, and as well as making the majority of AOA. When we compare and look at this graph a little bit differently, here we can see that, for example, black students, so in 1989, they made up about 5.4% of the student body, but only 1.4% of AOA, whereas now, jump forward 2015, they still only make about 5% of the student body, and now that percentage has gone down by half. And this study also controlled other objective factors such as your step 1 score, whether you made it into the Gold Humanism, and other awards as well.
So this isn't something that ends in medical school, right? This is something that goes on in residency. So this is actually a study in our specialty done in emergency medicine that was first presented here several years ago about gender disparities in residency milestone achievements. So if you're in education, you know that milestone achievements are supposed to be very objective, clean things that you can evaluate residents on, and they're not supposed to have bias, and you should just say how skilled someone is at meeting these objective milestones. But when they looked, they found that there's actually some gender disparities in how residents are evaluated. So we're going to focus first on sort of this green-blue line, and so that's the PGY 1 year. So interns coming out of medical school, men and women, and so you can see you're evaluated on a scale of 1 to 5, 5 being the highest, and the frequency is pretty much the same for men and women, the dashed blue and the solid blue line. So the biggest frequency is at level 2. So they're basically being evaluated the same on these different milestones. But you can see that by the time men and women get to the PGY 3 year or the senior year, there's a difference, right? Those curves no longer have the same shape. The women are being evaluated at a higher frequency at 3, whereas men are being evaluated at a higher frequency of 4, which is a higher level. And so that represents an achievement, a time gap of about 4 months in residency, right? So that's a big gap. And so trying to figure out, yes?
There's opportunity for questions.
Sure.
Was that consistent across all of the milestones, or were there particular areas that there was a larger disparity and other areas where there was more parity?
It was consistent across all of the milestones, but that's a great question. Yeah. And so thinking about why this is, so then following up to that, they did some qualitative work, right? So that was quantitative, based on numbers evaluation. So then a different set of researchers wanted to do qualitative work to think about why maybe those disparities were being found. And so they basically looked at the comments, the written part of residency evaluations. And they actually found other changes or differences in male and female feedback. So female residents are more likely to get feedback that's discordant or basically contradictory, whereas male residents are more likely to get consistent feedback, so sort of the same feedback across time from different evaluators. Similarly, female residents are more likely to get feedback that is personality-focused, specifically on two traits, autonomy and assertiveness, whereas male residents are more likely to get feedback that is very specific and skill-focused. And so what do I mean by that? Here's a couple examples. So the left side that's sort of in red is about a female resident. Says she argues a lot with the attending, she's very confident, and she has a hard time entertaining other possibilities. But someone else says she has appropriate confidence and autonomy, and yet a third person, she says she needs to be more assertive, right? What are you supposed to do with that? Too confident, appropriately confident, not confident enough. I will say that I personally have gotten this. I have gotten feedback. First line, too confident. Next line, not confident enough. What do you do with that, right? But then we have this male resident, his feedback. So his says you should not defer so much to the attending, confidently craft a plan. That he's capable, but that his clinical decisions are limited, and that he needs to keep working on expanding the differential. So while there's good constructive feedback there, it's all pretty similar, right? It's all consistent. He knows what he needs to work on. Similarly, men and women sort of have these same behaviors, male and female residents, but these behaviors are perceived very differently. So for a female resident, it says that she responds negatively to input and that she has a negative attitude towards supervision. Contrast that to the male resident. It says he's argumentative, but he's trying to assert his confidence, right? So you have two residents who are having the same behavior. Both of them are putting up a little bit of resistance to sort of the authority of the attending, putting forward their own plans. The female resident is seen as negative, having a negative attitude towards supervision. The male resident has the exact same behavior. He's seen as asserting his confidence. That's a positive behavior, right? So we're giving people different messages. Female residents are getting the message that they're negative, argumentative, and male residents are getting the message that they're appropriately asserting their confidence. So similarly, I'm sure you guys are familiar with the idea of agentic and communal traits, right? So agentic traits are things that are sort of individualized, are towards doing action things, whereas communal traits are traits that are more towards a community, so being compassionate, sensitive, emotionally intelligent. And researchers have sort of come up with a list of ideal resident in emergency medicine, and these characteristics for the ideal emergency medicine resident are team leader, takes charge, independent, decisive, motivated, confident, doesn't complain, doesn't get frustrated, which are all great traits. The thing is, though, all of these traits are typically agentic, and in our communities, our societies that we're raised in, are typically associated with men. And so what they found is that female residents are much less likely to be described using these words as compared to male residents. And so this isn't something that ends in residency, right? We're here at an academic emergency medicine conference, theoretically interested in moving forward in academia, but that this has impacts on who becomes leaders of our department, who becomes professors, who becomes chairs. And so you can see the trend of faculty. So these are the percentage of U.S. medical faculty who are female, and you can see sort of at the lowest rank, instructor, more than half are women. And every time you go up the ladder, that percentage drops, so that full professor is barely over 20%. And that this trend is consistent across a decade, right? So that women are making up more of the lower ranks, but really not reaching those higher positions. And this is also similar for race and ethnicity. So you can see that this is for male faculty. The white male faculty sort of are making up the largest percentage, and that you can see all of these other races and ethnicities are really unchanged, almost near zero across the past decade.
We're going to do a small exercise now. If you could take the bottoms of your pieces of paper, and this is an exercise created by Scott Horton, diversity consultant. He actually was the director of diversity and inclusion at IBM for 20 years. If you could write down a list of 10 people you trust most in the world outside of your family, could be people in your clinical roles, a workplace, leadership, just the 10 people you trust the most. Okay, so the purpose of this exercise, as we'll see, is to explore who we trust, why we trust them, and makes us ask the question, how might this influence how we evaluate others, and who we choose to promote, and how we do our evaluations of others. So we already know that implicit bias exists in evaluation, so what can we do about it? So we think about it in a three levels of change method. So individual, interpersonal, and institutional. So we can make changes on an individual basis, we ourselves, and how we behave and how we evaluate others. Interpersonal, so what we see peer-to-peer, and institutional, so what our institution is doing.
All right, so we'll talk a little bit more about the individual kind of step to looking at bias. So something that I'm also very passionate about is also exploring the biases that we have within us and how can we change those. If you have all been familiar with the Ayat, is anyone familiar with the implicit association test? So this was developed at Harvard by a social psychologist, Dr. Banaji, and also psychologist, Dr. Anthony Greenwald. And so this test was developed as a way to kind of elicit and uncover some of the biases that we may hold. This test that's free and available, I encourage everyone to do at least once or twice to really kind of see what it's like. But the exercise, you actually go through different types of biases: race, gender, religion, even obesity is a part of it, and they have even more tests, but it really kind of highlights the biases that are explored. What's really interesting, as long as this test has been out, it's been over 20 years that they developed this test, they see that there is consistent biases towards, for race, white preferences, seen by both predominantly white race, but also by black as well as for gender preferences towards women. And the way the test works, it really kind of highlights either a negative or positive word, and it's associated with a picture or a phrase that might be commonly associated with the gender or a race. So I encourage everyone to take this test to explore their biases. Next. So you've all received hopefully a green sheet of paper. So we just did the first exercise of thinking of our top 10. Now look at that top 10 and use this list that was developed by Dr. Scott Horton as a way to see what are the different qualities of the people that you trust in your top 10. So looking at gender, looking at race, looking at disability, looking at other factors and characteristics that they have, and then we'll come back as a group and share out that list.
Dr. Gisondi.
All right, so as everyone's filling out their list, did anyone notice any trends or certain characteristics that were predominant on their list of top 10? Yeah. Able-bodied, yes. Okay. Did anyone else have an overrepresentation of able-bodied people on their list as mentors? Yeah, that's right. Anything else? All female, yes, yes. I know I have the same thing where predominantly mine are all female and African American. Yes.
All of mine have MDs or PhDs.
Yes, so level of training and also kind of your career development. So your top 10 might shift, but definitely it might be predicated on your profession and what you do. But this exercise is just very brief as a way to look at, in the own communities that we work in and what we do, we're often biased by the people that we often spend most of our time with. So thinking about how that may highlight some of the biases that you hold, and just also looking at how do you expand that and reflect more differences. All right.
Yeah. So I'm Mike Gisondi. I'm the vice chair for our department. First of all, I'm very proud of our whole team for presenting this series of talks here at SAEM. I think they're wonderful workshops. And they're intended to give you tools. And what I hope that you'll walk away from this workshop with is not just an understanding of implicit bias or why it's important, but a few tools to take back to your shop to make things better. And that's really what I'm most concerned about in my administrative role. We have to do evaluations every year. I want to make sure those evaluations are accurate and reflect skill sets and not just implicit bias or personalities. I think that the role of administration in terms of mitigating this issue is twofold. One, you have to train your staff to do evaluations as fairly as possible, and then you have to make those evaluations as easy as possible to complete. So I think there's two paths that are important. A couple of tips and tricks that we're going to offer for you are as follows. First, there's a series of ways that you can look at an evaluation and pick out words similar to the way that you did at the first exercise, and find the phrase that represents implicit bias and then replace it. So, for instance, stereotypic replacement would be looking at a phrase such as in their urban community and recognizing that that probably has a racial, ethnic bias to it, and then taking those words out and replacing them with something else. Countering stereotypic imaging, if you think of Asians are good at math, tall black men are good at basketball, if you take a stereotype, pull it out of an evaluation and replace it with concrete evaluations that are, as we talked about earlier, agentic or communal, that are not necessarily gender biased. Individuation just says taking an individual and recognizing what their skills are as an individual and talking about those skills in detail. That requires you to get to know them well and spend time with them. When filling out the standardized letter of evaluation for years and years as a program director, I always put a first paragraph that talked about their path to medical school. So this person was born in this city, they went to this college, they got these degrees, they took this time off before they went to medical school. During medical school they did X, Y, and Z. And that was a trick for myself to clue in that I knew this person well enough to write their evaluation. If I couldn't write that forward material, why should I be able to write the rest of their evaluation? It's very important to train your evaluators to think about specific skills that individuals have and to look for their own bias in their evaluations. One trick would be to have a set of individuals write evaluations and then have another set of individuals be the check and balance on that, to look at the language and make sure that the language is appropriate. We just did a study this past year looking at the standardized video interview that the AAMC is using and compared it to assessments of professionalism and communication skills at 7 different residencies around the country. We found that using a standard rubric for evaluating folks during their interview day, we were able to remove any gender bias from our study. This is being published in AEM ENT. It's in press right now. The use of a standard rubric is very important, and that can lead to elimination of bias in terms of gender. It can lead to an elimination of bias in terms of race. It has to be very specific, though. You can't just put a 1 through 5 scale and say, strongly agree, strongly disagree, or they're wonderful, they're not wonderful. It really needs to be anchored with descriptors that remove any concern about personality and any concern about non-cognitive skills, that things that are going to be, again, more communal in the way that we evaluate folks. So, I would challenge those of you who are in administrative positions just to look at your own processes, make sure that your staff has been trained well, make sure that someone's evaluating the evaluations themselves and looking for bias, and be proud of the evaluations that your school is putting out. Make sure that you have touch points along the way that not only ensure that they're getting completed, but they're getting completed in the right way.
Thanks, Dr. Gisondi. So there's not a lot of research, actually, when it comes to institutional efforts to reduce bias. So if you're one of the researchers here, I think this is another area to really focus on because this is going to be the next step forward in order to really develop a structure for eliminating bias in our evaluations. There's a few things that we can kind of key in that we would recommend. So transparency and accountability is really important. People having some anonymous feedback may not necessarily help you in terms of getting to the core of the evaluation. And if you give them some assessment of, hey, I notice you keep on writing all these evaluations. If you don't have those ways to track it, then it's not going to be as effective. Right? It really needs to have a cultural change that Dr. Gisondi was just referring to, and that means that we have to train ourselves.
And there's also going to be an importance for tracking and trending a lot of the evaluations. Our groups of people tend to be grading one way versus the other, and if that's the case, let's have a discussion on why that is. And again, also the GME milestones and reviewing them is also very important. So now let's do train the trainers, because I think this is a nice opportunity for us to practice what we just talked about. So each of you have a copy of the blue handouts. What we're going to do is probably we'll divide this into 4 groups. There's like 4 different papers on the wall. So this corner over here will be one group, another corner will be another group there. And if you can rewrite the evaluation as a group and then write it on a piece of paper, it might give us a sense of, despite the fact that we've all kind of just got a quick training on evaluations, we'll still have variations of how we interpret this. And perhaps, like, as a group, we'll learn from each other and how we're going to be able to further refine our ways of using the language to accurately evaluate someone. We'll also give you some toolkits, the cards that you're going to be taking home with you, so that you can help yourself with these tools.
All right, guys, as we're all working on time management, I'm going to bring us back together here. I'm going to bring the time management back. We're going to all work on time management and come back together as a group. And I would like it if each of you guys would be willing to read the examples that you came up with. You guys look like you're done over here. We'll let them kind of scurry together at the end. Would you guys be willing to read the example that you came up with?
Yeah. So we didn't necessarily rewrite anything here. We just cut a lot of stuff. So,
okay.
For example, one, we captured the first 2 sentences. This resident is caring, compassionate healer. They have excellent interpersonal relationships with patients and families and are well organized. We struggled without context for that last sentence. If this truly was somebody, like if I were reviewing a resident who missed or was a little bit late for childcare, that's something that I probably would not ever put in a eval. I think most of our group did. If it was a frequent occurrence, we wouldn't put this on like a letter of rec or something, but we would just sort of objectively point out that at times that they have been late. But if this was a few times for childcare, we would leave it out. And then for example 2, similarly, we kept the first sentence. This medical student has performed at an expected level compared to their peers, although they did not participate enough during rounds. We would change the second part of that. Instead of saying they did not participate enough in rounds, we would encourage them to participate more in rounds, and then give them the kind of specific example, for example, by expanding their differentials when presenting. And then we, for the last sentence, just left overall their work was competent and would do well in whatever field they choose, and got rid of this whole family medicine, urban community garbage.
All right.
Can I make a comment on that? I think participation is such an interesting thing to pull out in evaluation, right? Unless you're deliberate at the beginning of a course to say that participation equals a better grade, you have to think about, does participation equal privilege, right? So folks who raise their hand in a room tend to believe that they belong in the room, and those who don't raise their hand sometimes feel that they don't belong in the room, even though they may know the right answer. So have you solicited participation from every single student in your class in a deliberate, meaningful way to test their knowledge? Or is it just simply those who feel like they belong to raise their hand more, and therefore they get higher grades? This has been shown over and over again in clerkship evaluations. Those who are just a little bit more talkative get higher grades.
Well, are you providing an environment that allows for equal participation?
Exactly.
Or is there something in the environment that prioritizes certain people, or so I think it's a more complicated, but I think the point is that.
Yeah. Participation always makes me a little nervous about inclusion and inclusive learning.
So our group focused on the first example. So the main goal of our group was that we wanted to cut out a lot of the adjectives, give more concrete details, and then, of course, we had an issue with that last sentence, too. So just to read out for everybody else what we had written, this resident is a dedicated physician. They are well organized, spends time to get to know their patients and families, which has translated to comprehensive care. They have been late to rounds on a number of occasions, which may be a problem. I agree with the previous group. I mean, bring up that they were late maybe for a couple of times for childcare reasons probably wouldn't add it, but if it's something that has been recurrent and they wanted to bring it up during the evaluation, then we wanted to put it in a more objective manner.
Great.
When I read evaluation say a number of times, I'm thinking more than two. They had a couple. So now I'm thinking, ooh, this is, just to let you know, I'm looking at it, I'm like, that may be a problem. Versus a couple of times, I'm going to say, oh, something may have happened. Just, that's my.
That's a good point.
I'm Ayat from the Uniformed Services University. So it's interesting to me to hear this discussion because I think about this in terms of the military fit rep or evaluation process. And it's a bit more standardized. And one of the things that they do that I really like in the military evaluations is that anytime there is a deficiency or if there's something negative, it's usually noted whether or not the person's been counseled and what measures have been taken to address it. So,
That's a good point.
So if it's a thing like they've late a certain number of times, were they counseled and
Thanks, Catherine. Sarah?
I think it's really important to think about what the purpose of the evaluation is. If it's a summative evaluation or if it's a formative evaluation, if it's for internal use with the CCC and to try to give the residents some insight into their problem areas that they need to work on versus something that we write as a kind of please hire this individual, right? So that they have two completely different purposes. If you soften things and make things so vague in a formative evaluation, that you may miss some of the messaging that the resident needs to hear. It's just
That's a good point.
The first part, the caring and compassionate, I always struggle with that because you do want to point out people who really are caring and compassionate, but it becomes a buzzword not to use. So my colleague here had a good suggestion about the resident emphasize the traits of a healer. At Mayo Clinic, we often say to exemplify our Mayo Clinic values, so we sort of substitute that in there, which I thought was a good part. You want to do the last?
Sure. We also highlighted that the resident has excellent interpersonal relationships with patients and feelings and are well organized, which I think goes to the traits of a good healer. And like everyone else, we left off a lot of the details of the tardiness and child care issues and said they did have a few excusable late absences. And I think it's important to highlight that that is an issue such that the individual could be refer to HR or other resources to help them with child care issues if that becomes a recurrent problem.
I like using specific examples as opposed to just saying healer because it really highlights the actions as opposed to some descriptive things. All right, last group as we wrap up.
We did the first one, and we so the resident demonstrated compassion and excellent interpersonal relationships. The overall, they're well organized, and we would have liked some more specific sort of positive examples to give there. So as evidenced by blank. And then, so I guess for the first part, we were just trying to sort of balance wanting to keep in compassion as a valuable trait, but not wanting it to be sort of so strictly female, or like recognizing that's not always what's like valued for promotion, et cetera. And then for the improvement area, we just tried to keep it more objective. The tardiness, A, just to offer it as an area of improvement, and B, like keeping out the sort of child care and presumptions.
Great. So kind of thinking through what we've done here today, thinking how you can bring this back to your own institution, looking through evaluations for medical trainees and how you can reduce bias where you work, how can you standardize evaluations. I don't think we quite have time to each go through, but kind of just think to yourself, what are 1 to 2 things you can take back from today's workshop moving forward, right? We've talked about, and you've got the little cards to go home with, but different strategies for knowing people better, for providing specific examples, having an example, in your head for someone you want to describe. I sometimes am asked when I'm about to graduate in a year, but asking for letters of recommendation. And I think one of the things that I ask for when people write me letters is I ask, could you think about me as a man when you write this letter? Picture me as a man in your mind when you write the letter, and go through, or going through and making sure that it doesn't read as a specific person, so that if you were to read this letter, you wouldn't be able to tell who it's for, what their gender is, what their race or ethnicity is, right? Because you want to have specific skilled examples. So I guess in summary, implicit bias negatively impacts evaluations for trainees. Unfortunately, or fortunately, right, for better or for worse, we don't live in a vacuum. We all have grown up in a society that has conditioned us to see people in different ways. Even if we're aware of those biases, we still have them, and so does the world around us, right? But thankfully, there are strategies for helping to mitigate these biases, including sort of standard objective evaluation processes. And it's really important to be aware of these biases, especially if you are an evaluator, because as we see, these evaluations have huge ramifications, starting in medical school, moving forward in residency, and really impact careers in academic medicine and sort of who we bring into the family of medicine and emergency medicine moving forward, how we're going to lead this field forward. So thank you so much for coming and spending your early morning in Vegas with us. I know it's early, and thank you very much for coming. We'll take any questions that you might have. We have a bit.ly here.
If you put your QR camera, it will actually give you the link to our notes. And after today's talk, we'll upload a lot of the notes that we have, so you can take it home with you as part of the toolkit.
Yeah.
We thought maybe you're going to get a lot of handouts today, and this way you don't have to lose them.
But again, thank you so much for coming. We'll take whatever questions you have, and then otherwise, enjoy the rest of your day and the keynote speech. Thanks.
We have another talk tomorrow at 11 o'clock. No, actually, it's 1 o'clock. It's going to be an abridged version of the workshop that we had yesterday, which was a 4-hour workshop on implicit bias, microaggressions, and the imposter syndrome. So we hope to see you there.